Hello and welcome back. Today, I am recording my very first episode after having my 2-week holiday to Thailand. So if you follow me on social media, you'll know that I went to Thailand for a holiday. And this is the first holiday I've had in over 3 years, which, I mean, it doesn't really feel that long. Like 3 years, I'm like, oh, 3 years, I haven't had a holiday. But in reality, it feels like forever. In that time, I have moved 1, 2, 3, 4 times. I've moved house 4 times. I was single and now I'm engaged. And it was actually also my first holiday with my fiance. So I was a bit nervous about whether or not I would come back still engaged. Not really. We had a great time. It was fantastic. I could talk about that holiday in forever. I had the most incredible time. I have previously, my holidays were to, like, I haven't been to Thailand, but I've been to Bali, and Bali holidays were like, book a resort, stay in the resort, get massages, drink coconuts, do nothing, fully relax and chill. And I thought that's what this holiday was going to be about, but I was wrong. And that is because my partner is super into like really experiencing the culture of countries. So we did all like touristy things, but we also like did all this stuff that was not really that touristy because my partner Ben wants to like immerse himself in the local people's lives. So we went to these towns where there was like pretty much no tourists. Nobody really spoke English, although some people did really well, and then others just had no clue. And the food was not Western-based Thai food, that's for sure. Neither were the toilets. But it was an incredible experience. And I honestly would not have done that if he had not planned it. I want to say I can be a bit precious in some degree. Like I wouldn't voluntarily choose to do these like super regional remote Thailand experiences. Like we went to this one lady basically she was a tour guide, but a tour guide in Bangkok showing people like around the tourist sites. And I didn't do any of this. My partner did all the organizing. He actually contacted her and organized for her to take us around her village, which was like the middle of nowhere, living on a farm on a concrete slab with like a roof over it, with like basically collecting food from the land and cooking it. And it was honestly the biggest eye-opener. Like I see this stuff on YouTube and you kind of know about it, but until you've seen it and been in that for the whole day, I just don't have any words to describe it. It was like I was freaking out the whole time of like, well, 1, getting food poisoning, 2, the toilet situation, 3, like I just felt so uncomfortable being in that environment and thinking about how these people live. But at the same time, I was so incredibly grateful for everything that we have, but also like, wow, these people are so happy, so unbelievably happy, and they seem like zero stress. Well, they didn't look or feel stressed. Like I need to take a lesson from these people's books because this is not the Western culture way. Anyway, I could talk about this holiday for days, but we did all this adventure stuff. And then the last couple of days, we went to Phuket to basically lie on a beach and be hippos. And that was my part of the holiday that I organized. And it was probably the worst part. So note to self was organize your holidays better. And if Ben is listening to this, which sometimes he does listen to my podcast, he will be like, I told you planning was a good idea, because his version of planning is like plan everything. And I'm like, let's just go there and like work it out when we're there. And then you end up doing nothing. So anyway, holiday was fantastic. I would love to just talk about it, but you're not here for that. You're here for pelvic floor health. And I am going to be sharing with you the research paper that I shared in the last email that went out for the research spotlight emails. And this one is like, I mean, I say this about every research paper, like this is my favorite one, but this is one of my favorite ones. And I think it's because I'm sharing all of my favorite ones to start with, because I've only just started the research spotlight emails, which everybody seems to be loving. I mean, the people that have replied to me and told me about it really are enjoying it. So I hope that you did. And I also think that like I actually got some feedback in the mentorship program this week, I gave them like a feedback form because I'm all about optimizing experience inside a service. And I don't know how to make something better without the feedback from everybody in there. So if you are a clinician and you are scared to ask for feedback in fear that it will be bad, that is the gold. The gold is the bad feedback because you can get better. So you have to become a little bit more comfortable with asking for feedback, but two, also accepting not so great feedback or things like, don't get offended, because like if you really want to improve something, you have to actually acknowledge the things that maybe you're not doing so well, which is like a mindset business thing. But yesterday I got this feedback, and the feedback was basically like she'd said, I really hate research papers. I've always found it really, really difficult to read them. So my least favorite part of the actual mentorship was the research papers. And I think like I used to feel like that. I hated research. I remember doing research at uni and I was like, this is the dumbest subject. Like, why do I need to learn how to read a research paper? Like, I'm just going to go out there and be practical. And I never really understood the value of it. I also found like reading them made me feel so stupid because half of the time I didn't know what the words meant. The formatting is so hard to understand sometimes. And I'm like, this isn't really replicable in real life. So like, is this actually relevant? Who knows? Anyway, I think if rewind the clock, if I was feeling the same and someone sent me an email that was like, here's a research paper, here's the key points, here's what I take away from it, and here's how I apply it in my practice in a real life scenario, I would love it. So I'm hoping that you feel the same way about these research spotlight emails and like me discussing them with you, because I would have really liked that. And I feel like maybe the feedback from this particular mentee was like, oh, there's other people that hate reading the research. So maybe just hearing it and hearing how it's applied in a really like chill way is helpful. So if you want to receive those emails, you're not already on the email list, the link is in the like little description of this show. So you can click on there and join if you would like to get them once a month. On the first of the month, I share that with you. So the next one will be December. Anyway, back to the research paper. I have it here. So if you're watching this on YouTube, you'll see I'm a highlighter, I'm a sticky noter, and I'm a writer on the actual paper. And that is because these were things that I was like pulling together to put inside the mentorship as like, I guess I want to say evidence of why I do what I do. So anyway, the title of this research paper is An Alternative Intervention for Urinary Incontinence, Retraining Diaphragmatic, Deep Abdominal and Pelvic Floor Muscle Coordinated Function. The reason why I love this research paper, is because one, it's a randomized controlled trial and I like to see what happens in two groups. And I can pick and choose which bits I like, versus like the last one I shared before that was actually the review. Was it a review, I think? And the whole thing was basically golden. So yeah, I like the randomized controlled trials. The second part of this is that it is all about retraining the system, which is like a muscle coordination thing and movement-based thing. And this one in particular actually moves through progression in a sense of the programming. So I'm going to be referring to my notes here on my screen. So if you're watching this YouTube and I'm looking away from the screen, that's why. Now, so let's start by diving into like who was in this trial. So people were recruited for this trial and they were basically eligible, they were female volunteers, and they were basically deemed eligible if they were experiencing stress urinary incontinence or urge urinary incontinence. So it didn't quite matter which one they were, but they were then allocated these women into two groups. So one group was the training group and the second group was the control group. So both groups were actually given education around like the anatomy of the pelvic floor, the urinary system, like continence mechanism and how that all works. So they both had exactly the same education. They were internally examined for vaginal squeeze pressure, as well as instructed on how to correctly contract the pelvic floor muscle as well. So everybody had that. So that was part of their baseline measures, were squeeze pressures and pelvic floor contraction. And then when we look at what they did differently, the control group received oral instruction and information covering urinary incontinence, pelvic floor muscle exercise, and bladder hygiene, whereas the training group were given a 5-stage exercise regime designed to retrain diaphragmatic, deep abdominals, pelvic floor muscle, like coordination as a whole. So the training group was also told, like none of them were told to do isolated pelvic floor muscle exercises, basically. So good to see how actually, do you know what? I think they were. Let's have a look here. I'm just reading this paper because I have written down here that participants in the control group were instructed not to perform isolated pelvic floor muscle exercises, but I feel like that's wrong. Were individually taught anatomy of the pelvic floor, lower urinary tract, and continence mechanisms. Oh yes, okay. So to avoid contamination of exercise effect, participants were asked not to perform the isolated pelvic floor muscle voluntary contraction exercise during the intervention period. That was in the training group. So only in the training group. Yeah. So we didn't want to see like, pelvic floor isolated exercises having an impact on here. So let's talk about what they actually did in the 5-stage exercise regime. So it basically went through 5 stages of progression. And there is an appendix in the paper that actually tells you what the exercise regime actually was, which I love because there's nothing worse than being like, oh, I'm reading this newspaper. I'm reading this randomized controlled trial and they're talking about all these different exercises and programming, but you don't know what the actual exercises were. So it's not helpful. Anyway, the exercise regime. So they went through 5 stages. The stages were diaphragmatic breathing. 2nd stage was tonic activation of transverse abdominis and pelvic floor. 3rd level was muscle strengthening of transverse pelvic floor and internal obliques. 4th level was functional expiratory patterns. And the 5th level was impact activities. So in the appendix, it actually shows you the diaphragmatic breathing they did from weeks 1 to 4. The position they were in was in lying, sitting, and standing. And the home exercise program was 30 repetitions, 3 sets per day. So it actually goes into depth. So I would recommend you go find this paper. I'll link like the research paper in the notes below so that you can find it. But it's so helpful. So then the 2nd phase was tonic activation of pelvic floor and TA, and that was from weeks 2 to 5. And they actually did this in standing, which I was like super surprised with straight off the bat, that they were like, let's get into standing because I teach this in prone and in supine prior to standing because gravity has like a huge impact on the pelvic floor. So if you can't actually get it without the gravity effect or postural play of muscles, you're going to have a hard time actually retraining it. So yeah, they did that. And then tonic activation with ADLs and walking was stage 3. So this was where they sort of started to, I guess, bring it into a daily activity. So basically they were asked to hold the tonic transverse activation and pelvic floor muscle co-contraction in upright positions when they were doing activities of daily walking, daily living, so activities in standing and walking, which I think is pretty cool. So that's like learning how to use it in these functional activities. Not the type of functional activities that I would go to, obviously being an exercise program, mine are more strength-based, but this is really easy to implement in most people that aren't doing weightlifting or training. So if you just see people like this is helpful. Then they worked on muscle strengthening. So this was basically then targeting like holding the contractions for a little bit longer. And they were also repeating that quite regularly. So it was more like long holds of the same sort of exercises that they were already doing. And then the next phase, which was phase 4, is functional expiratory patterns. So this was nose blowing, coughing, laughing, and sneezing. So those higher pressure activities. So if we're thinking about most people are going to leak urine in coughing, laughing, sneezing, and nose blowing. Not such a common one that I've come across, but definitely is. Then they have to basically, the goal of this was to create a co-contraction at the right timing against high pressure. So these activities were, I guess, programmed as a practicing and like repeating these. What did they do? 5 repetitions times 2 sets per day. So I guess they basically picked whatever they did and then did their co-contraction as they were coughing, laughing, or sneezing. So I guess coughing you can practice quite well, or laughing. I mean, imagine laughing being part of your home program. That's actually quite cool. And then the last one was impact activity. So this was from weeks 10 to 16. And this was basically then co-coordinating all of this into it says here into impact activities such as running, jumping, and dancing. And the home exercise is just according to the participant's activity schedule. So they can just basically do this, and they want to be able to maintain the co-contraction during walking for more than 15 seconds in order to get to this. So this was the prerequisite. So like I said, the programming in the actual paper is crazy. It's like, it basically goes from what position it is, what the home exercise is, and what the prerequisites are in order to move to the next phase. So this was like a 16-week progression. So, and it goes through. So go get yourself that paper and have a read of it, because I bloody love it. Because the results from this paper honestly make me like, oh, this is what exercise physiologists and I guess super passionate fitness trainers who see women with pelvic floor issues that have the capacity to program functional training and integration of all of this stuff into movements. Like, it just makes me feel like, oh, this is it. This is where we sit. Because I really love movement, and I really believe that movement and retraining muscle function and like looking at the pelvic floor from a whole body perspective is so much more beneficial than just like looking at the pelvic floor and only treating that, which I mean is important at some point in the rehab process, obviously early on, really acute, but like it's not enough. And too many women get stuck here and do it for too long, and they don't understand how to even do something like this where they go through these phases of progression. It doesn't even have to be through exercise, like programming, like, you know, leg extensions and tabletop holds and bird dogs and glute bridges and hip thrusts and squats and things like that. It can be through nose blowing and laughing and just adding your TA contraction and your pelvic floor co-contraction, or whatever you want to call that, into walking. Like it's actually quite easy to progress this. It just never seems to get there. So I really feel like this is where we sit, and this is what is so valuable for us as like movement-based practitioners, right? So let's talk about what they actually measured in this study, and then we'll talk about the results. So in the outcomes of the study that were measured were self-reported improvement. They did 20-minute pad test whilst performing activities that included coughing, Valsalva, deep knee bends, jumping up and down on the spot, and walking up and down stairs. So measuring the pad test in those activities. 3-day voiding diary, where they were asked to record every event of voiding, urgency, leaking, as well as describe the amount of leaking. They did pelvic floor muscle function, including maximal vaginal squeeze, pressure, and holding time. So this was in the internal examination. And then the impact of incontinence on health-related quality of life. So those were the outcomes that they measured. The results that were significant in this study blew my mind. 96.7% of women in the training group reported improvements in symptoms versus 66.6% in the control group. That is a 96.7%. They call it in the study cure or improvement rate. That is actually insane, because it's insane. It's so good compared to the control group, which was just like pelvic floor education, pelvic floor squeezes. Still great, not superior. There was significant improvement in the 20-minute pad test in the training group, whilst the control group did not have any improvement in the pad test. Those in the training group significantly reduced the number of leaks per day. And there was more improvement in quality of life markers, or what they measured in the quality of life questionnaire, reported in the training group. Those results, honestly, are fab. Improvement, curing rate of self-reported symptoms, which is like the most bothersome, right? Like most of the time when we're looking when we're as EPs and we're looking at measures, it's always like, what are you measuring and what's the percentage of improvement in actual measurable outcomes? But it's like reporting it means like they feel better about it. They think they're getting less symptoms. They feel better about it. Their quality of life improves. Like that's more important to me. And they had improvement of life, improvement of quality of life markers. Pad test was like actually improved. So that was significantly better. And that's because like when you think about that pad test assessment, they were measuring like leaking in coughing, Valsalva, deep knee bends, jumping up and down on the spot, and walking. And that's what they've actually trained. They've trained the co-contraction of pelvic floor, deeper abdominals, breathing mechanisms in those activities. So they're going to see improvements, which is why movement in pelvic health and where they experience their symptoms is so, so important. This is exactly what we should be doing. This is what our skill set is for. And I am like so passionate about this because I felt so inferior to physiotherapists for a very long time because I didn't know how to assess and identify whether a pelvic floor symptom was more tightness-based, prolapse-based, weakness-based, whether it was a mixture of all these. I didn't know how to actually prescribe exercise beyond the like laying down, turning on your pelvic floor, or like practicing your Kegels in the car, like you would have learned like from Googling it. And it felt really degrading as an exercise professional. I was just like, what am I supposed to even do in this field? Like, I'm supposed to be this university qualified health practitioner, and I know less than a personal trainer because I don't really, well, at the time I was a PT, but I felt like I was a personal trainer. And then I had to refer out for like all of this acute training. I'm like, what do I even do with my skill set? What is the point of this? And it wasn't until I'm like, I actually need to learn how to do this. I need to learn all of this type of exercise prescription, progression, how it's important to bridge that gap between the acute pelvic floor work into personal training, high impact running, and all of this other stuff. So if you feel like that in your skill set, man, I get you. I hear. And it is such a crap place to be quite honest, because it just feels like you went to uni and wasted your time. Anyway, this program, this prescription intervention is basically a superior program to isolated pelvic floor muscle training. And this is what you can use to actually help your clients too, to improve their pelvic health symptoms, their quality of life, their actual symptoms, how they feel about their symptoms. Like it's the same thing. You can basically take this away and go for gold and use it yourself. But I mean, I guess the problem is actually like, how do I do this? How do I actually do this? Which is the hardest part about being an exercise professional is like, they've given you a pretty good guide here. I mean, you could pretty much just follow this really if you wanted to. It's actually got a prescription, 5 reps, 5 sets per day, holding the contraction as long as possible and gradually increasing the holding time to 40 seconds. So if you have no idea where to start, that would be it. Now, if you want to go down the more exercise programming route, you actually have to learn how to do this. And it is not easy because it takes a lot to actually identify what works and what doesn't, and then see what symptoms are really similar across clientele so that you can like pull knowledge and experience from other people. So when I think about like mastering how to actually prescribe this and how to program this to actually get results, it really requires understanding everything about the pelvic floor, pelvic health, movement, how to integrate it all together, how to assess movement to identify when someone's movement pattern is maybe contributing to like poor coordination or co-contraction of that system. And it actually requires a lot of exposure to a variety of different clients that have pelvic health concerns, and then constantly applying and practicing this so that your skills actually develop. And this does not happen when you only learn the basics. You don't you go to like that 2-hour course or the 1-hour webinar, or maybe you do a weekend course on it and you learn it and then you go away and you try and apply this yourself, except something pops up that doesn't actually fit into what you learned and you have no idea what to do. So you kind of just don't apply it. And then you just hope that somebody else comes along that's a little bit easier. And that's how I started this journey. And then I think I became really like confident in my ability to ask clients like, hey, I don't really know if this is going to fix your problem, but like I've been reading about this and I would love to try it and see what happens. Are you okay to like give it a go? It might not work, could make your problems worse. And they were like, yeah, sure, let's do it. And that was like, obviously I developed a lot of trust and rapport with these clients, but and they were like more long-term clients. I was also PTing people at the time, so it did help. But I just kind of like picked and choose things and saw what worked and then kept tailoring it down, and only saw pelvic health clients. So that's all I see. I don't see anyone else. So I don't forget what I'm doing. I repeat it constantly. I refine it constantly, and it helps me with my prescription and my confidence in programming. So, I mean, you don't have to go that crazy and niche down, but I would really recommend, if you are wanting to get into pelvic health and being really good at it, you have to niche a little bit by like seeing them more regularly, practicing regularly, learning a lot, and then actually also maybe even like having a support network of people that allows you to ask questions. Because if you go away like you do from that weekend course and you apply something and it doesn't work, how do you know how to change it? How do you know what to do? Like, where do you get advice for if you get stuck at level 3 of their progressions and they don't actually get to that next level and you don't know how to get them there? You don't get results for them, and then you kind of feel like you can't do what you're supposed to be doing. That's when you need help. You need to be able to ask someone. You need to be able to say, hey, this is what I've tried. What else can I do? There's not very many environments I've felt like workplace environments where there's always someone above you who does that same thing that you want to do, but is already really good at it. So like I've worked in a couple of clinics before where there's no other women's health guru. Like I was the women's health EP, even though I wasn't that advanced, I was that person. So I had no one else to ask questions to, and I had to go build relationships with other people that were willing to share information with me that also weren't competitors in our scene or like, you know, next door in the clinic. So I found that so hard. So if you are also feeling like that and you're feeling very lost, then, and you want to learn how to do this, I mean, maybe you don't want to learn and that's okay, but if you really want to learn how to do this, this is exactly why I developed the mentorship program. One, I wanted to really make a difference in the reputation of exercise professionals in women's health, because I'm sick of everyone being like, see a women's health physio and get a referral to them and get your internal check done and then do your exercises and like you should be good to go after that. Like I'm finding that scene is like, oh, I can just help just as many women. And some women don't want internals and some women can't access internal work. And sometimes they don't gel with the practitioner that they can see, or they have to wait 6 months to actually get an appointment. And we as exercise professionals can do those non-severe, really clinical population where we can actually, like maybe they don't need to have an internal straight away. We can get started on other things, teach them movement, teach them mechanics, give them education, and then progress them into all these other things. And then they can go do their internal exam when they actually can get into their appointment or if they want to. So I'm a really big believer in that. So that's one reason why I created the mentorship. Two was that I really found it difficult to find anything that was like actually supported other than here's a self-paced program or here's like a weekend, have fun, go do it, practice it on your patients that were pretend patients because they were members of the, like they were also attending the education and there wasn't actually a problem with them. So you wouldn't feel like what's wrong or what to do if things didn't really go to plan, or you weren't trying to explain core anatomy to someone who had no idea about anatomy, because all of us professionals already know this, so it's easier. And then you went out, you got stuck, you had no one to ask. Hate that. So the mentorship is completely supported for this reason. I also hated the fact that most of these education programs are like, here's how you treat one-on-one clients in a clinical scenario, or this is how you this is how to train. Oh, I mean, I haven't even been to one of these, but I'm sure there are some out there where there's like group class programming. And it's like your individual workplace is going to make applying material so difficult, because if you work in a hospital, if you work in private practice, if you work in group training, if you work as mostly a PT in a gym, how you apply what you learn is actually really difficult. Because I have people in the mentorship who are like, I work in a hospital, so I don't actually get to see people regularly. How can I help them with their symptoms if they can only come once a month? Then I have people who are like, I take group classes because my clientele base is people that want to be in group classes. So how do I teach and assess and like individualize pelvic health in a group class? So that's another reason why the mentorship is highly supported, because it's got one-on-one aspects for that reason. And then there's also the community side. So we can ask questions 24/7, collaborate with your fellow peers inside the group. This year has been fantastic. We're sharing information that I don't even know about other pathologies or maybe other musculoskeletal issues, because mostly pelvic health falls under those categories, and they can share with each other. So like I've learned some new exercises that I didn't use previously that I think are actually super valuable. So like even just collaborating on that is so great. So the mentorship is designed for all the reasons that I found it really difficult to learn alone. And it took me years. It took me pretty much, 7 years, I reckon, or maybe at least 5 years to really feel like I knew what I was doing, to then like basically continue and keep going and getting better at it. But it took me that long to do this by myself. And I pretty much give you everything in this little parcel of program, course, mentorship, whatever you want to call it, so that you can just learn it all and do all of that without having to take as long as I did. Because if you want workplace satisfaction or career satisfaction and you want to feel really good at your job, you don't want to wait 5 or 6 years, because if you're not persistent and patient, you'll give up or you'll transition to something else because you're just like, oh, I still don't really know what I'm doing. I'll just like go down this path instead because I have access to this type of mentoring from my workplace or whatever that might be. So moral of the story is, if you want to learn any of this, how to actually prescribe all of these exercises through phased protocols, because it's exactly what I do. I take people through a 12-week program that is phased. I pretty much give it out to you. I give templates out to you, case studies of the same thing in the mentorship so that you can pretty much plug and play it into your own workplace. Then it's going to be opening soon. It's opening on the 4th of December for 2024 to kick off in January. There's only 10 spots in the program because I give so much support and I don't have the amount of time to give any more people support. So if you would like to be in that, I'm only opening it to the waitlist. If the waitlist, for some reason, the people on the waitlist don't want to be part of it, then there's spots left over, then I'll open it up to the broader audience, but be on the waitlist. So I'm going to put the link in the description below, but I also have goals around building some smaller versions of pelvic health, because I know not everyone wants to dive deep like this. So that's probably not going to happen for a while, but I know that if there is interest, if you're interested in something like that, please let me know, because the more people that are interested, then I'll actually do it. If no one wants to learn small snippets of pelvic floor health, won't bother doing it. So yeah, let me know if that's something that interests you, or other women's health education that you might be interested in as well, because there's not a lot out there and I would like to help. So there you have it. How to basically create a program or an alternative method of prescription to help with pelvic floor problems such as incontinence and urinary urgency, backed by research, or the whole thing's based on the research paper. I've linked it all below. Go check it out. And if you want to be part of that if you want to be part of the email list where you get the research sent to your email inbox, join the list. I'll put that below. You'll get it. The next one will come out on the 1st of December. So otherwise, in the meantime, have a fantastic day from wherever you are. Thank you once again for joining me. If you like this, please share, and let's change how professionals of movement and exercise are seen within the women's health industry.